So we'll start first with the definition and etiology of your fungal infections. So when talking about etiology, you have to classify them according to the location, to the epidemiology, including morphological classification. Now, first, in relation to your classification by location, you have the fungal infections that can primarily cause mucocutaneous infections. Though mortality here is very low, but they can be problematic in some patients because this can be a reason of recurrence, and at the same time, it can be cause also of temporary physical disability. But more or less, the prognosis here is good as long as you're able to diagnose and treat them. The other group in terms of the location is the deep organ infections. And this is the type of your fungal infection that can really affect mostly vital organs. And if you will see later on with my with the topics, with the different invasive fungal infections, it can be some of them is life-threatening, carries a very high rate of mortality, and most of the infections or the population that are involved here or affected are the immunocompromised host. Then in terms of epidemiology, you have two classification, both the endemic infections, which are usually fungal organisms that are inherently present in the environment, but because of a decreased immune system of patients, then they are they can easily be transmitted and acquired, and sometimes it can also be severe, especially for those who are immunocompromised. Now, to differentiate the endemic infections from opportunistic infections, opportunistic infections are usually caused by fungal infections or fungus that are also not in the environment, but some of them are usual commensals in our body, but because of decreased immune response, especially for those who are or who have malignant conditions, including HIV, then we call it the opportunistic infection. So they are only causing symptoms and severe infection once the immune system of an individual is down. Okay, so that's the opportunistic infections. Now, based on morphological classification, you have three: the yeast form, the molds, and the dimorphic fungi. Now, to further classify the physical forms and growth conditions differentiating between yeast and molds. Okay, so this is when you talk about yeast, the basic examples here is your fungal infections caused by cryptococcal infections, no? Your cryptococcus. So they come in two forms. You have the round single cells or the budding organisms. Now, Candida, okay, Candida species can be either a yeast or mold depending on what tissue or is it in the tissue or is it in the organ. So which means that Candida can both be a budding organism, can also be a hyphal organism, except for a Candida species, glabrata and oris. So commonly encountered molds usually in the filamentous forms, you have your aspergillus, mucorales, and your dermatophytes. Now, to further classify fungal infections, we need also to examine and be able to know that there are specific microorganisms that are really opportunistic and are known to be opportunistic. And there are also those that are, aside from being opportunistic, can also cause deep organ infections. There are also fungal infections that are not opportunistic but can also be mucocutaneous and are endemic. No? So one of that is your Candida infections. Candida can be opportunistic, can also be mucocutaneous. Aspergillus, same as Candida, can also be opportunistic but can also cause deep organ infections. Same as that with your histoplasmosis and that of your mucormycosis. Now at this point, this will be the next group of our topic, which we will be elaborating specific fungal infections based on its classification, as I have mentioned. And this is the time that I will be doing a lot of this emphasis on the type of the fungal infection, the clinical syndrome that they produce, the organ that they usually are affected, and the risk factors, meaning the factors in a patient why they are infected or why they acquire that specific fungal infection, and what tests are very important for us to diagnose and document the presence of each of these fungal infection. So first we'll discuss the mold or the filamentous fungi. Aspergillosis. So you have here the different species. The most common is your Aspergillus fumigatus. Then you have also the other Aspergillus species, Therius, flavus, niger, and nidolans. Now, the most common clinical syndrome that patient will have when they get infected with aspergillosis is either in the form of pneumonia or a disseminated infection. So meaning it can affect multi-organs, not only the lungs. Okay, and this is common if you have pneumonia or disseminated aspergillosis. This is common among those who have neutropenia, especially with an absolute neutrophil count of less than 200. Those taking high dose of your glucocorticoids or steroids, patient who are transplant recipient or post hematopoietic stem cell transplant recipient, those patients who recover from influenza infection, and even who had COVID-19. So remember during the COVID-19 epidemic, when India reported a high number of patients with COVID-19 co-infected with aspergillosis, no? So they call it the black fungus during the time. The most common clinical manifestation is also pneumonia. And the co-infection with COVID-19 and pneumonia in patients with aspergillosis was really associated with a very high mortality. Now, in some patients, they can also be getting aspergillosis after they are on immunomodulatory agents, treatment of cancer in the form of your BTK inhibitors. Then we also have a form of your aspergillosis, like your acute bronchopulmonary aspergillosis and keratitis that is also common among those with atopic individuals, while for those keratitis usually results from direct inoculation of an infected part of our body, and that can also cause morbidity. Now, how will you diagnose aspergillosis? Later on, most of this fungal infection, the diagnostic test will vary from culture of the fluid that is available, especially for pneumonia. You'll be using your bronchoalveolar lavage fluid. Uh, it has a low sensitivity, non-specific, because the test cannot differentiate between colonization and contamination. Remember that aspergillus can also be colonization of the upper respiratory tract. The more sensitive and more specific test is histologic examination of tissue. So most of these fungal infections should need histologic examination for you to define and be able to see the acute angle septate hyphae. Biomarkers or markers that are specific for a particular type of infection, like your galactomannan and your beta D glucan, can also be used as an adjunctive diagnostic test. And the problem there is that they are non-specific because they can also be positive with other fungal infection. Next is your mucormycosis. So mucormycosis, you have commonly you have three very important species here. Your rhizopus, your rhizomucor, meaning a combination of your rhizopus and your mucor, and the third one is your mucor. Now, this type of your fungal infection usually affect the sinuses and then goes down to your lungs. So we have sinopulmonary infection. In fact, if you have patients with mucormycosis, especially the mucor species, then it is also one of the most common cause of rhinocerebral infection. And it can also cause necrotizing skin infection. Now, does not infect just any individual, especially immunocompetent, but specifically for those who are immunocompromised, those with neutropenia again, hematopoietic stem cell transplant recipient, patients with diabetes uncontrolled leading to ketoacidosis, and can also get this infection during a direct inoculation. Okay, so again, if the patient presents with a sign of pulmonary infection, the best specimen to send for examination is the culture of your um, bronchoalveolar lavage, either using the pulmonary fluid or the sinus tissue, though low sensitivity but highly specific. But again, histologic examination will be very helpful because it will appear like a ribbon-like acetate hyphae. Now, there's no biomarker available for the diagnosis of your mucormycosis. Then you have the third among your filamentous fungi. You have your fusariosis, which also can cause lung infection or disseminated infection, and keratitis, especially for those patients who have or who are neutropenic. Again, the use of culture of tissue or blood can also be helpful in recovering the microorganism, the Fusarium solani, which is the most common among this species, and then you need histologic examination to demonstrate the acute angle septate hyphae, and also the use of your biomarkers in the form of your galactomannan or even your beta D glucan, but are non-specific for the diagnosis of your fusariosis. The other group of your filamentous fungi is your pseudosporiosis, which is also the one of the few fungi that can in this group, the species that is commonly encountered is your Pseudosporium apiospermum, which can cause pneumonia or disseminated infection. And again, it is common among those who are neutropenic, those taking glucocorticosteroids, and then those who are post hematopoietic stem cell transplant recipient. Just like with other filamentous fungi, you have culture of the fluid that is infected. So if the patient has pneumonia, you can use your bronchoalveolar lavage and then its histologic examination and the use of your biomarkers. Then the other group of your mold or fungi is your phaeohyphomycosis. Okay, so you have here a group of quite difficult to pronounce species of your fungus. But again, just like your mucormycosis, this is one of those that can also affect the sinopulmonary infection. But this time, to differentiate this from mucormycosis, it can also cause central nervous system infection or meningitis. Okay, and this is quite common in patients again who are severely immunocompromised, those who are neutropenic, steroids. But aside from the one that we have mentioned about these risk factors, you should not be surprised that in some healthy individuals, it can also cause central nervous system infection. But most of the time, majority, this is usually confined to immunocompromised individual, whether it's through direct inoculation or patients with atopic disorder, then this is one of the common infection that can also be present in these patients. Then we have also the two common skin and nail infections uh, cutaneous type of fungal infections that's quite common even in healthy individuals. So which means that you don't need to be immunocompromised to get this infection. You have here your dermatophytosis. These are so common, like your trichophyton, microsporum, and your epidermophyton. And usually, dermatologists can really differentiate which among these is the cause of your dermatophytosis. No? So it's so easy to diagnose based on the appearance of the lesion, but for you to specifically diagnose which is trichophyton or microsporum, then you need to do a fungal culture of the scrapings or clippings in the nails or in the skin, and then you will be able to see the chains of arthrospores, which is diagnostic in patients with dermatophytosis. Use mycetoma is another type of skin and subcutaneous infection. Okay, the classic example of this fungal infection is your Madurella mycetomatis, which is also common in individuals that are healthy. You don't need to be immunocompromised. And again, the examination here is usually with use of a culture or a macroscopic examination, wherein you will be able to examine the grains harvested from biopsy or aspiration of an infected skin or subcutaneous infections, usually in the lower extremity of healthy individuals with eumycetoma. Now let's proceed with yeast fungi. And this is a big group that are commonly encountered, especially among patients who are immunocompromised. The first among these is your candida infection. So your candida infection, you have two types, your mucosal candidiasis and your invasive candidiasis. Now, the examples of your mucosal candidiasis is the oropharyngeal or esophageal candidiasis, which is quite common among patients with HIV. Also among those patients with on high dose of your glucocorticoids, and especially for patients with several episodes of use of antibiotic, there are those who are highly prone to vulvovaginal candidiasis. No? So vulvovaginal candidiasis is not a sexually transmitted infection. So mostly among patients with antibiotic use, you can have a higher risk of vulvovaginal candidiasis. Now, how can you diagnose mucosal candidiasis? It's so easy and not so expensive. You just need a 10% potassium hydroxide, and then you will mix that potassium hydroxide as a staining solution with your vaginal discharge or your esophageal tissue or wet preparation, and then you'll be able to put it in the microscope and you will be able to elicit the presence of your yeast or pseudo hyphae. Okay, and then you have also your culture of mucosal surfaces for a while. Minute.
Dr. Jean,
Yes.
kailangan ko ng wisdom.
Nag-lecture pa ako, fungal infections.
Sige.
Sandali lang. Sige. Okay, thank you. Sorry, that was Dr. Rosario, no, calling. So you have that mucosal candidiasis now. Now, your next group of your yeast or fungi is your invasive candidiasis. So what are under this? Of course, Candida albicans is still part of your invasive candidiasis. You have here a group of big group of non-albicans, no? So we call this a non-albicans candida. You have your glabrata, parapsilosis, tropicalis, and the very difficult to treat, no? Candida auris. Okay. So what does this mean when you have invasive candidiasis? So it's beyond being able to infect the mucosal area, but it can be a source of an infection because of its ability to affect any organs or deep organs. And that's why to document this, usually with the use of your blood culture. So any blood culture that will grow a Candida albicans or what we call the non-albicans, then that is already considered candidemia. Okay? And this is common among critically ill patients, especially admitted in the ICU. So again, meaning for you to develop candidemia, it doesn't mean that you are severely immunocompromised. If you stay in the ICU longer, you have a lot of this antibiotic and risk factors for candida, which I will also discuss later on. What are these specific risk factors that will increase the risk of these patients who are in the ICU can also get candidemia. But the other group here is your disseminated infection, which means that the infection has already spread to the spleen, to the liver, kidney, to the eyes, heart, and central nervous system. So this group of patients are the severely neutropenic patients or those who are on prolonged corticosteroid treatment. So how will you diagnose patients with invasive candidiasis? The most important test here is your blood culture. The only problem with your blood culture, you have a very low sensitivity. So which means that if you get a blood culture and you have a patient with invasive candidiasis, chances are it may not grow in the blood culture, but it doesn't mean you have absence of your invasive candidiasis. That's why histologic examination is also important. But again, you need tissue. So which tissue? Spleen, liver, kidney. Then you'll be able to isolate and demonstrate the presence of yeast or pseudohyphae based on that histologic examination. Or you can also use as an adjunctive diagnostic test the use of your biomarkers, your beta D glucan, or even your T2 magnetic resonance in whole blood. So which means there's a way of increasing the presence of your candida in the blood by looking at this T2 magnetic resonance as a biomarker. Okay. Now, the third big group of your yeast infection is your cryptococcosis. Okay. So I think most of you are aware that cryptococcosis is common among those who have HIV. Okay. And we see a lot of this, no, in the Philippines. We have patients with HIV when they present with encephalitis or meningitis. The first diagnostic differential there, you have to highly entertain the presence of your Cryptococcus neoformans. No? So you have two species here, your Cryptococcus neoformans and your Cryptococcus gattii. Gattii is not common in the Philippines, okay? And I have not encountered yet a patient with gattii. This is usually common in Western countries, but the one that is common in the Philippines is your Cryptococcus neoformans. Now, aside from meningoencephalitis or meningitis with encephalitis, patients with cryptococcosis or fungal cryptococcosis can also cause pneumonia and osteomyelitis. Okay, so usually cryptococcosis can be inhaled. So usually it's in the environment, and when you are immunocompromised, you can inhale it. It can initially cause lung infection before it can go to the central nervous system. Rarely, it can cause osteomyelitis. No? So the most common infection here in patients with cryptococcosis, if that will appear in your examination, meningoencephalitis. And who are the patients highly vulnerable to this? Number one is the patients with HIV. In non-HIV patients who will develop cryptococcosis, usually these are patients with glucocorticosteroid treatment for a longer period of time, or those with sarcoidosis, or those taking some of these immunosuppressive drugs like your interferon gamma or your GM-CSF and your BTK or JAK inhibitor treatment of malignancy. Now, how will we diagnose patients with cryptococcosis? Culture of your CSF. If the patient presents with CNS manifestation, if the patient presents with pneumonia, then you have to get bronchoalveolar lavage, no? Because when you just examine the sputum, it's so the detection rate is very low. So either you use a bowel fluid or a CSF if you have patients with pneumonia or a CNS infection, or you can also grow cryptococcosis in the blood, no, by using your blood culture. Now, using microscopic examination is also part of a very important test to diagnose cryptococcosis. For example, if you have a patient with meningitis, okay, we will send your CSF aside from culture, you'll send it for staining. The stain that is commonly used here in the Philippines to diagnose cryptococcal meningitis is your India ink. Okay, although in this literature, in this reference, you can use your GMS or your Gomori methenamine silver or your Musi carmine stain, but we don't have that here in the Philippines. It's not readily available. So what we use is the India ink, which is very cheap and easy to do. You just get a drop of your CSF and put the India ink in a slide and then look at it in the microscope, and you'll be able to see the encapsulated yeast. Okay. Now, biomarkers. Cryptococcal infection has a specific biomarker in the form of your Cryptococcus antigen, which can be tested either in the blood or in the CSF. Okay. If your patient is cryptococcal antigen positive, that's very sensitive, that's specific. That means that is another way of diagnosing your patients with cryptococcal infection. Then the fourth group of your yeast or fungi, you have your trichosporinosis. Okay, so trichosporinosis, just like your dermatophytes, is also a yeast, but usually commonly affecting the skin. Okay, so the specific clinical syndrome secondary to your trichosporinosis is your white piedra. No? So it's a superficial skin infection, and usually it is also can be found and common among healthy individuals. But in some patients with trichosporinosis, it can also affect the eyes. It can also affect the skin, and that is why we call it disseminated infection, which means that it can affect outside the skin, including the eyes. And this is common among those patients with neutropenia, patients taking glucocorticoids, patients who are post hematopoietic stem cell transplant recipient, or solid organ transplant recipients, like your post kidney transplant recipient. They can also get this disseminated infection of your trichosporinosis. How do you define, or how do you isolate the microorganism? We do blood culture, or we do culture of the tissue that is involved. Histologic examination, of course, you can see yeast, hyphae, and arthrochonidia. Very characteristic there is your arthrochonidia, and the biomarkers that can also give you additional diagnostic input there is your beta D glucan, or the BDG, that can also be positive. Again, this is just an emphasis that your biomarkers in most of these mold or yeast fungi can be positive. No? So meaning it's non-specific. Most of this fungal infection, you can be positive with these biomarkers. Now we go to the endemic dimorphic fungi. No? So as I mentioned, endemic, that is in the environment, and usually they can be acquired by those who are immunocompromised. Okay, the first among this is your histoplasmosis. Okay, so you have one very important species of your histoplasmosis that is also seen in the Philippines. No, and I have seen some of these patients with histoplasmosis, your Histoplasma capsulatum. The other species here that is only present in Africa is your Histoplasma duboisii. Okay, so histoplasmosis usually can infect the lungs. Okay, but in those patients who have HIV, patient post solid organ transplant recipients on immunosuppressive agents, they can also present with a disseminated infection. No? In fact, 2 months ago, I have a patient with HIV and AIDS who present with disseminated histoplasma infection involving the bone, the liver, and the skin. Okay, and there was also severe bone marrow involvement, wherein the patient present with severe neutropenia and severe pancytopenia. Okay, so that's how bad histoplasmosis can be, especially if you have if you are severely immunocompromised, those who are already in the AIDS stage of those who are HIV positive. Okay, so how will you diagnose the presence of histoplasmosis? In my patients, we did a histologic examination of the skin that was affected, no? And you see there the characteristic yeast with narrow-based budding. Now, culture of the blood or tissue, we did also that, but we were not able to isolate histoplasma. And remember, the culture or blood here, culture of blood or tissue has a very low sensitivity, and sometimes you need to incubate them more than a week for you to really isolate the microorganism. Other tests that is available, just like your cryptococcal infection, you have a cryptococcal antigen. Histoplasma, you can also have the histoplasma antigen, but I don't know if it is available in the Philippines, if this is can also be used in our setting, but this is part of the test that you can use in the diagnosis of your histoplasma. And the antigen for histoplasma varies in terms of increased positivity. The highest rate of positivity is when you send it when you send the urine, then you have the serum, and the least among the isolation or positivity of your antigen is your bronchoalveolar lavage fluid. And again, just like other fungal infections, your beta D glucan can also be positive as a biomarker for your histoplasmosis. Then you have your next group of your endemic dimorphic fungi, your blastomycosis. Okay, so this the most common species among this group is your Blastomyces dermatitidis. Now, so elaborate here that most of these patients with blastomycosis, they usually present with a disseminated infection, okay? Either a disseminated infection involving the skin, the bone, the mucosal surfaces, including genital urinary tract, but there are also, okay, patients who presents with pneumonia, particularly healthy individual, no, can present with pneumonia. But if this patient will have blastomycosis and in the form of a disseminated infection, always remember these patients are severely immunocompromised. And that's where you'll have AIDS patients with glucocorticosteroids or those on immunomodulatory agent in the form of TNF alpha inhibitors. How will you diagnose blastomycosis? Again, just like your other endemic dimorphic fungi, it's the culture of the tissue or the uh, bronchoalveolar lavage in patients with pneumonia. Again, it has a very low sensitivity. You need to get tissue for you to isolate and diagnose and confirm with the presence of your yeast with broad-based budding, just like your histoplasma. So the difference here is that your histoplasma has a narrow-based budding, while your blastomycosis is a broad-based budding of your yeast cells. And then you also have your blastomyces antigen, which is also an antigen that is specific for blastomycosis. But again, it can have a cross reaction and can be positive also with your histoplasmosis. Okay. Now, the next group may not be so common, but also are an important cause of your fungal infections in the group of your endemic dimorphic fungi. The first among these is your cocci iodomycosis. No, so you have here the specific commonly cause of this is your coccidioides immitis. Usually, again, can be self-limited pneumonia and disseminated infection, even in healthy individuals, but can be disseminated in patients who are immunocompromised, like your patients with AIDS, glucocorticosteroid treatment, long-term, and patients on TNF alpha inhibitor. Just like your paracoccyl iodomycosis, it can also cause pneumonia and disseminated infection. And again, can also be found in among patients who are healthy. And the most common presentation is a self-limited pneumonia or pneumonia. But once it can have a disseminated type of infection, which means can affect two or three organs, then most likely that patient is immunocompromised. And the most important risk factors there are patients with HIV or patients on steroids. So your paracoccyl iodomycosis usually can be again isolated through culture. Then you can also use histologic examination using a potassium hydroxide preparation. So a while ago we discussed potassium hydroxide preparation as a staining method for patients with candida. You can also use this in patients with paracoccyl iodomycosis. Okay, so that's how the endemic fungi are. And then the next group here are not so common. No? So you have sporotrichosis and your thalaromycosis. No? So your sporotrichosis usually infect the lymphocutaneous area. Okay, so they can cause lymphangitis. Now, this type of infection is usually confined among patients who have HIV/AIDS or those on glucocorticosteroid treatment. No? But in some patients, it can be acquired infection through direct inoculation, so through contamination. Then your thalaromycosis, again, a not so common type of dimorphic fungi. The most common species here that is being exemplified with your thalaromycosis is your Thalaromyces marnefi. So this is an infection that is commonly causing disseminated infection in patients with HIV and AIDS and those patients on immunosuppressive drugs. Now, Tularomycosis can also cause pneumonia, but mostly in healthy individuals. And at times, the prognosis here is good, no? Unlike your other fungi. Okay, so the rest I will not specifically mention because these are not so common. Your Aedes spiromycosis, your emergomycosis, and the chromoblastomycosis. No? So these are patients. These are type of your endemic dimorphic fungi that usually are not in the top of the list in terms of causing higher mortality and higher morbidity. Now, the last among these major fungal infection is your pneumocystis jirovecii infection. Okay, so this is the only fungal infection wherein the treatment is an antibiotic. Okay, so which means the other groups are antifungal, but this one is an antibiotic, no, with the use of your cotrimoxazole. So pneumocystis jirovecii, the most common clinical syndrome, are patients who will present with pneumonia. Okay, and again, this is one of the most common causes of severe pneumonia that can really present with severe hypoxemia. Patients with HIV, especially for those patients with HIV whose CD4 T cell count is less than 100. Okay, so if the patient is an HIV positive and the CD4 T cell count is less than 100, then they are high risk for to develop a pneumonia. That is what we call the PCP, no, caused by your pneumocystis jirovecii. We have also encountered patients with CD4 count of less than 100 and already with disseminated type of pneumocystis jirovecii. It can also affect the eyes, the central nervous system, the gastrointestinal tract, and the skin. So how will you diagnose a patient with pneumocystis jirovecii infection? This infection cannot be cultured. So meaning you cannot do culture because it's not culturable. You cannot isolate this in blood or in what other tissue based on culture. Okay, so the gold standard for the examination of your pneumocystis is the use of a stain, a specific stain that will be able to isolate the microorganism, your pneumocystis jirovecii, and that is your Gomori methenamine silver stain or the DIF-QUIC. So this is also available in the Philippines. Some countries can use immunofluorescent stain, but this is also expensive. No, so Gomori methenamine silver is at most the stain that we use for pneumocystis carinii. There are also biomarkers that can also help us diagnose a patient presenting with severe pneumonia, HIV positive. You can use also your beta D glucan, but again, it's non-specific. Your bowel fluid PCR is also not specific. It's sensitive but not specific, and sometimes it's difficult to differentiate if the pneumocystis there that is present is a colonization or a true pathogen. No? But granting that your patient is severely immunocompromised, presenting with hypoxemia, with severe pneumonia, and the bowel fluid is positive for the pneumocystis jirovecii PCR, then that will be significant and considered as pathogen. Now we go to the host defense against fungal infection. Why is this very important? Because as I've mentioned in the previous slides, that most of those vulnerable to any fungal infection or to the major fungal infection, there are specific immunocompromised conditions. HIV/AIDS, patients taking steroids, patients taking immunosuppressive drugs. Okay, so these are the most common predisposing factors. So which means that until such time that your immune system is okay, then chances are most of this fungal infection you will not be infected, no? But again, there are other fungal infections that I have mentioned can also be occurring in healthy population. So what's the first host defense against fungal infection? The presence of your cells in the epithelial cells. No? So this is your Th17 cell. Your Th17 cell will now be able to produce your interleukin 17A, 17F, and 22. Okay, and these cells are the one that is responsible for the protection of individual to get a mucosal candida. So remember, your candida infection usually starts in the mucosal area before it can also invade in the blood. And this type of your Th17 cell should is a vital part of your host defense that can be of help to prevent candida yeast and going into the blood. The other aspect here is that your Th17 cell also can be a modulator to promote differentiation of your STAT3. No? So you have the STAT3 in the skin that can also protect us to mediate epithelial proliferation and repair, produce antimicrobial peptides that will inhibit growth of your candida infection, specifically candida infection. So that's how the immune cells, no, our host defense can be very valuable in patients with if you want to be protected against specifically candida infection. Now the next group of our host defense is the neutrophil. Okay, the neutrophil in the blood, okay, can activate a specific modulator, the CXCR2. Okay, and usually this CXCR2 is usually stimulated when you have a patient with Aspergillus infection. Okay, so it starts first with a lung infection, and then once the Aspergillus goes into the blood, then our immune system, if it is intact, our blood will produce neutrophil and specifically will produce the CXCR2 that will lead to a cascade of event that will produce your NADPH pathway to produce these superoxide uh, substances to prevent your aspergillus from reproducing inside the neutrophil of an infected lung. Okay, so that's the most important uh, protection, no, against an infection that is usually common in the lungs, specifically activating our CXCR2 positive contained in the neutrophil. Then the last among these host defense against fungal infection is the presence of your Th1 cells. So again, kanina we have Th17, then the neutrophil that is carrying your CXCR2, and then the third one is your Th1. Okay, so your Th1 cell, okay, will now stimulate also your macrophage. So your macrophage will produce specific substances, and this is the specific host defense that will protect us against pneumocystis and cryptococcosis. Okay? Aside from your Th1 cell that will activate the macrophage can also subsequently produce your interleukin 12 that binds to its receptor on T cells, okay, and activate your STAT4, which consequently will stimulate the release of your interferon gamma, which will now bind to your macrophages and activate your STAT1, enabling fungal killing. Okay? And then the third in this Th1 cell pathway, you have tumor necrosis alpha and GM-CSF that are also critical for macrophage activation. Okay, so you have those three pathway of host defense that you'll have an idea that if you will be taking immunosuppressive drugs, if you are severely immunocompromised because of the positive presence of your HIV, or you are taking immunosuppressive agents like your tumor necrosis factor and other newer immunomodulatory inhibitor, then that this is the pathway that will be affected, why some of these fungus can proliferate and specifically involve several organs. Okay, so this is just a summary of the different pathway. No? So taken together, these observations show that the cellular and molecular factors that drive the protective antifungal immune response vary vary greatly with the anatomic site of the infection, the offending fungus, and the patient population. So those are the three very important factors wherein you need to observe when you have a patient with fungal infection, why these patients are prone to develop a CNS infection or a multi-organ infection or a deep-seated infection commonly caused by a specific fungus, and of course the patient population wherein most of these patients are really the ones that are what we call symptomatic. Okay, now we go to the diagnostic test. So if you look at this fishbone analysis, no pathway of diagnosis of fungal infection, it starts with number one, the most important, histopathologic identification. So I have discussed that in the previous slide. Histopathologic identification will be able to distinguish different fungal infection based on its morphologic features, as I mentioned, or the use of a specific stain in order for you to be able to appreciate that morphologic features. Then we also have the culture technique. No? So either in the form of a blood culture system, automated, it can detect early the microorganism because it's automated, or using the conventional lysis centrifugation technique. So that's the culture using blood. Then we also have serologic tests, no? As I mentioned a while ago, you have antibody, you have antigen test, and then the newer advanced diagnostic method now is with the use of your T2 magnetic resonance or your MALDI-TOF. Okay, so this is the overall diagnostic modality of a patient with fungal infection. Now, I just want to dive into the different staining or stains that are being used to diagnose the fungal infection based on histopathologic appearance with the use of this stain. So the most commonly used stain here is your periodic acid skip. No? So this is mostly in any fungal infection, but there are specific stains that can really be that can also be diagnosed with the use of your gram stain is your candida. No? So your candida can be in the form of a yeast or a budding yeast or a hyphal elements with the use of your gram stain. As I've mentioned a while ago, Gomori methenamine silver can also be used as a way of looking at the presence of your pneumocystis jerovicki. And then the India ink stain for the diagnosis of CSF, the presence of your encapsulated cryptococcal microorganism. Okay, so these are the histopathologic stain that are available for the diagnosis of your fungal infection. Now we go to the antifungal agents. Okay, now antifungal agents, unlike your bacterial or antibacterial, also has a different pathway on how they will inhibit fungal infections. Okay, first, the most common and the oldest among the fungal infection is your amphotericin B. Okay, so amphotericin B remains the broadest spectrum antifungal agent. Okay, how does it act? How does it kill your fungus? It directly binds to the ergosterol, which is very vital in the nutrition of your fungus. Okay, and intercalation into the fungal cell membrane, which will eventually lead to cell lysis, no, of the fungus. So that's the mechanism of action of your amphotericin B. Now, among the antifungal drugs, this is one of the broadest spectrum because it really is the drug of choice of most of these both invasive and mucocutaneous fungal infection. But again, the problem with your amphotericin B, you need to balance also that yes, it is effective, but it also comes with a higher toxicity. Okay, so what's the most common toxicity related with your amphotericin B? First is your infusion related reaction. So meaning when you infuse this drug into the patient, it can cause phlebitis, it can cause fever. Okay. Now in some patients, It can also cause renal toxicity. So which means that it can cause renal dysfunction. So these are the drawback, no? When you use your amphotericin B, you need to monitor the creatinine, you need to monitor the hemoglobin because it can also inhibit your erythropoietin and can cause anemia. It can also cause hypokalemia because of the infusion-related reaction. Despite the fact with this, the presence of this toxicity, always remember this is the preferred agent for patients with mucormycosis, patients with cryptococcosis, and even the other invasive infection like your Candida infection. Now, if you look at the evolution of your amphotericin B, because of the toxicity, there are now new formulations that are effective but less toxic, no? That is common with your amphotericin B deoxycholate. And these are in the form of your lipid formulation, either in the form of your liposomal amphotericin B or your amphotericin B lipid complex. I repeat, no? So there are two lipid formulations. So one is your lipid formulation and one is the original formulation, which we usually use in developing countries like the Philippines because of its lower cost, even at the expense of a higher toxicity. But when you will be using your lipid formulation, this is expensive, this is more effective, toxicity is very low, tissue penetration is very high, very good, highly effective. Okay? So these are in the form of your liposomal ampho B and your amphotericin B lipid complex. Okay? So what is the drawback here? There's no drawback. The only drawback, probably, if you call it a drawback, is the price of this drug, which is really 3 or 4 times higher than that of your amphotericin B deoxycholate formulation. Now let's go to the next big group of your antifungal agent, the azoles. Okay, so the azoles, compare it with your amphotericin B, the mechanism of action here is inhibition of your lanosterol 145 demethylase and your ergosterol synthesis in the fungal cell membrane. Can cause, once it is accumulated, then it can arrest the growth of your fungal or your fungus. Okay, unlike your amphotericin B, remember, azoles are considered fungistatic. Okay, so they are not as potent as that compared to your amphotericin B. And that's the reason why that there are selected use of your azoles in terms of its indications. But the azoles now has also evolved, no? And I will discuss that later. So you have the advantage of your azole is you have an oral formulation. Your amphotericin B doesn't have an oral formulation. At the same time, it is safety for the kidney, no? So you don't have to worry about renal toxicity. So the first among these azole is your fluconazole. Okay, fluconazole application and considerations is quite varied. Okay, you can use it in any patients with molds and dimorphic fungi, patients as part of a treatment combination in patients with cryptococcal meningitis, patients with invasive candida that is in the blood, we call it candidemia, and we can also use this as prophylaxis among patients who will undergo transplantation, patients with coccidiodal meningitis, mucosal candidiasis, azole-resistant candida, and other prophylaxis. No? So you have a very wide range of indication. Now, there are pros and cons with the use of your fluconazole. What are the pros? It has multiple formulation. It has both IV and oral. It has a long half-life, so meaning you can give it once a day. It is a it has a broad body fluid penetration with less toxicity, except that it can sometimes cause liver toxicity. Okay, what is the cons? No, so out of this benefit, you have the cons. You have a dose that you need to give it at a high dose, especially for those with invasive fungal type of infection. And that's where you will be able to circumvent the fungistatic activity by giving a high dose of this drug. Okay, It has some risk of miscarriage if you also give it to pregnant individuals, especially during the first and second trimester, and can also cause stillbirth. Okay, so currently, the third among these azole is your itraconazole. Okay, your itraconazole is both can be an oral and IV formulation. Okay, the indication is mainly for molds and dimorphic fungi. So that's why here the current indication of your itraconazole ranging from histoplasmosis, blastomycosis, coccidioidomycosis, phaeohyphomycosis, sporotrichosis, and even mucocutaneous mycosis. Okay, so the drawback here is that itraconazole cannot be relied on in patients with CNS infection, okay, because of its very poor penetration and at the same time very limited stability. Then at the same time, because of its variable absorption in the blood level is unpredictable. So that's why you need to regularly monitor the blood level, which in the Philippines we don't have that capability, no? The therapeutic drug effect. So when you use this, you should be careful because there is also a chance that it may not be so effective. Even with the current indication, you have to carefully uh, monitor the patient because of adverse event, and sometimes it can also cause CYP3A4 inhibition, which can also decrease the availability of some drug, causing drug-to-drug interaction. Okay, so all of these reasons are the main reason why when you will be using itraconazole, you'll have all of this disadvantage, and this limits the use of your itraconazole. Now comes the latest among the azole, the voriconazole. Okay, so what's the advantage of your voriconazole over that of your fluconazole, itraconazole? Okay, so your voriconazole is one of the broadest antifungal drugs. Okay, broader than fluconazole. Why? Because it's active against fluconazole resistant Candida glabrata, Candida krusei, is highly active against Aspergillus, Pseudosporium, and the other endemic dimorphic fungi except Bucor. Okay? So the other advantage of your voriconazole is that it can also penetrate into most body fluids, especially in the CSF. In fact, it is a preferred agent for the treatment of aspergillosis. The only problem here, because of a very good drug, okay, it's really very expensive. Okay, so it's so expensive. Three, four times more expensive than fluconazole. Okay, the only drawback for your voriconazole, aside from drug-to-drug interactions, no, so there are also drugs you need to know what drugs are these that can be inhibited by your voriconazole for absorption, and that's the reason why it cannot be effective. It can also have what we call toxicity related in the liver. Okay, so you have hepatotoxicity. It can also be you can also have visual disturbances, okay? And some patients will have manifestation of rashes now. But based on clinical experience, the drawback here that I really am not a fan of your voriconazole is the ability to cause liver toxicity, and sometimes there are patients will have difficulty in visualization, no? Because of visual disturbance. Now, the fourth group or the fourth example of your azole is your posaconazole. Okay, so posaconazole is broader, has a broader activity than voriconazole. So meaning you have the higher the azole now, you have a broadest activity. And this is the azole that is highly active against mucorales. No? It is approved for antifungal prophylaxis in patients with neutropenic leukemic patients and patients who are hematopoietic stem cell transplant. No? So meaning prophylaxis when you undergo uh, um, um, chemotherapy after with patients with leukemia or transplant recipient, you have to give posaconazole within the first 3 months for you to prevent fungal infection. The advantage here, you have both oral and IV formulation. Okay, so that's the current status of your posaconazole. Now, the newest among the azole is your isavuconazole. Okay, so isavuconazole comes also with an oral and IV formulation. Now, what is the advantage of your isavuconazole? This is now the approved treatment for aspergillosis and mucormycosis. Okay, so remember, kanina sabi ko, mucormycosis, posaconazole, aspergillosis, voriconazole. But this one is another drug with the list of the side effect. Okay, lower toxicity, broad antifungal activity because it's effective both for aspergillosis and mucormycosis, and at the same time, unlike your voriconazole, it has a fewer drug-to-drug interaction. Okay, so to differentiate this with voriconazole, your voriconazole has more drug interactions, higher toxicity, and the efficacy established focuses on aspergillosis. Okay, so you have more of an advantage of your isavuconazole over that of your voriconazole. Now, the other big group of your antifungal agents is your echinocandins. Okay, so first we have amphotericin B, then we have your azoles, and then now we have your echinocandins. Now, so your echinocandins specifically inhibit your 1,3-glucan synthase, an enzyme that is crucial for fungal cell wall synthesis. What is its advantage over the other previous antifungal agents that I have mentioned? First, it is a fungal agent that has the least of the toxicity. Okay, whether it's renal, it's liver, it has the least. Okay, highly very tolerable and safe. Second, it is the antifungal with the least drug-to-drug interactions. Okay, so there's not much list of drugs that will be inhibited or that will be absorbed less when you give it together with your echinocandins. And this is a drug that is active against all species of your candida. Okay, so which means if you have a patient with invasive candidiasis and you don't know yet the specific species, and that patient is severely immunocompromised, toxic, then this is the better choices, no, compared to your amphotericin B and your azoles. Okay, so all of these echinocandins have the same efficacy, toxicity, and drug-to-drug interactions. But again, the safest among all these, the antifungal drugs. Now, another group is your flucytosine. Okay, so your flucytosine is also a very potent antifungal drug. Okay, why? Because aside from fungicidal, it is the drug that has one of the highest penetration in the central nervous system. Okay, and that is why that when you are treating patients with cryptococcal meningitis, this is a drug that will really be an important determinant of response to patients with cryptococcal meningitis in combination, no? In combination with your amphotericin B or fluconazole. Because remember, you cannot give this as monotherapy, no? You cannot give this as monotherapy. The only drawback here, you should monitor the CBC because at times when you will be giving this drug, it can cause bone marrow suppression. It can decrease the hemoglobin. It can decrease the platelet. It can decrease the WBC, and it can also cause liver toxicity. Okay, so these are some of the challenges and considerations when you will be using flucytosine in patients with cryptococcal meningitis. Yes, you have a drug that is very good in terms of CSF penetration, rapid decline of the cryptococcal microorganism in the CSF. It's because of its fungicidal activity, it can sterilize your CSF, but it should be given as a combination therapy. But on the other side, okay, you cannot give it as monotherapy. You have to monitor the CBC because of bone marrow suppression and liver toxicity. So that's to balance only that when you will be giving this drug, you have to closely also monitor the patient for the adverse event. Okay. The next group is your griseofulvin and terbinafine. No? So these are drugs that are highly active against cutaneous, okay, type of your fungal infection. What's the pros and cons here, especially with your terbinafine? It's effective against onychomycosis, okay, the fungal infection in the nails, effective against ringworm, okay, And then the only cons there is that it has a poor tissue penetration and should not be used in any type of fungal infection that is systemic. Okay. Again, just like your voriconazole, just like your flucytosine can also cause liver toxicity. That's why you need to monitor also the liver enzyme. The latest among these new antifungal drugs is your Ebrexafungerp. Okay, this is an oral antifungal agent that belongs to a new class of your glucan synthase inhibitor called triterpenoids, potent against Candida species, and currently the only approved indication for this particular antifungal drugs is in the treatment for vulvovaginal candidiasis and recurrent vulvovaginal candidiasis. Okay, so topical agents, antifungal, these are so common. Most of these are over-the-counter drugs. You have your clotrimazole, miconazole, and your ketoconazole. Okay, and usually this is the go-to treatment, no, for patients with topical or cutaneous mycosis. Okay, now as I promised, I will be talking also some specific fungal infections that are so common in the Philippines. And as a doctor, as a future doctor, and you'll be encountering this type of patients, it's important for us to be aware of this selected fungal infection. Okay, your cryptococcus, no? Your cryptococcosis. Why I'm mentioning this? Because the Philippines is one of the fastest country with the highest number of HIV and AIDS, no? And the Cryptococcus is declared as one of the critical priority pathogen by the WHO in 2022, no? So what does that mean? Meaning this is an infection that is common among immunocompromised, the HIV/AIDS, and the treatment always entail a combination of the amphoB, flucytosine, and fluconazole. And the problem is that in most developing countries, your amphoB is so expensive, flucytosine is not available, and sometimes it's only fluconazole, but you need a high dose of your fluconazole. No? So that's why it's part of the critical priority pathogen. So the overwhelming majority of patients with cryptococcal infection occur in patients with HIV and AIDS, especially for those with CD4 count less than 100. No? So that's why I was telling you that most cases of cryptococcosis occur in resource-limited regions of the world, and that includes the Philippines. So what's the most common clinical manifestations? As I've mentioned, the most common clinical manifestation is meningoencephalitis and patients presenting with pneumonia. So that's the information about cryptococcosis. Now, Candida, one of the most common also in the Philippines. Okay, so you have here a list of your species. You have the most common, your albicans. Then you also have the down the line of this list are your non-albicans. You have your Guillermondi, Crusei, Parapsilosis, Tropicalis, Lusitanae. You have your Glabrata, and of course the multi-drug resistant type of your Candida emerging. Candida auris. Okay, multi-drug resistant meaning there's no optimized antifungal yet available here in the Philippines. No, so that's why you need to pray that this Candida auris may not be infecting your patient because that's so difficult to treat. Now, there are two types, as I mentioned in the previous slide. You have mucocutaneous and deeply invasive candidiasis. Now, I would like to focus here that there are specific conditions that will really increase the risk of patients that the candida can be hematogenous and can be disseminated. First is your antibacterial agents. Patients who have several episodes of antibacterial agents will also have higher risk of candida. Those patients with intravenous indwelling catheters, like your IG cath or central line, patients on hyperalimentation fluids, patients on indwelling urinary catheters, patients on steroids, severe burn, patients with cardinine deficiency, patients who undergo abdominal and thoracic surgery, on cytotoxic chemotherapy, immunosuppressive agents for organ transplantation, patients on mechanical ventilators, myeloperoxidase deficiency, neutropenia, low birth weight, and diabetes. Okay? That's why it's one of the most common candida infection in the hospital because most of these patients usually have all any of these risk factors. So when you have any of these risk factors and your patient will present with infection, invasive candidiasis, then that risk factor is the one that is the culprit that your patient, why your patient develop invasive candidiasis. Okay, now treatment. What's the treatment of choice? It also depends on the site of the infection. So for most mucocutaneous candidal infection, usually with the use of your fluconazole. Okay, so most of these, whether it's vulvovaginal, oral, or esophageal, the preferred treatment is your azole, mostly oral. Like for example, if you have a vulvovaginal candidiasis, you need to give 150 milligram of your oral fluconazole. But if it is an oral thrush, you can give it in the range of 100 to up to 200 milligram. Same as that with your esophageal candidiasis. Now, if the infection involving candida is already disseminated, so which means deeper organs, invasive deep organ infection. As I've mentioned, you have this formulation. You can use your amphotericin B formulation. You can use any of this azole, posaconazole, fluconazole, voriconazole, or the least toxic, the least drug-to-drug interactions, and one of the most effective is your echinocandins. And your echinocandins, you have four drugs here: caspofungin, anidulafungin, micafungin, and the newest kid among the echinocandins is your rezafungin, which is not available in the Philippines. Okay, so you have three of these agents that are highly active against deep organ disseminated candidiasis. So I just have to show you here some of the systemic manifestations of an invasive candidiasis. Being invasive, sometimes you can see them in the skin. Okay, so this is what we call the typical macronodular skin lesion associated with hematogenously disseminated candidiasis. So this patient is an immunocompromised patient who was positive for Candida albicans, and part of the clinical manifestation are these skin lesions. Then it can also cause eye infection, no? In the form of your endophthalmitis. So here you have the classic off-white lesion projecting from the chorioretina into the vitreous, causing surrounding area to be haze. No? So patients will have some visual disturbances in this type of eye involvement of your candida. The next group is your aspergillus. Okay, so aspergillus is also underreported, but can also be but is also present in the Philippines. Okay, so what are the primary risk factor for invasive aspergillosis? Patients with neutropenia, glucocorticosteroid use, and those patients with underlying chronic respiratory disease. So you have three types of your aspergillus, no? One is your invasive, which commands with a very high mortality rate of 100% if not treated. Then you have your chronic pulmonary aspergillosis, in which the mortality is 50%, and this is one of the most common compared to your invasive because this is usually predisposed with a chronic lung infection. And in the Philippines, the most common among these is patients with tuberculosis. Okay, and then the least among these is your the most common among these is your allergic bronchopulmonary aspergillosis. No? But this is only this is a type of infection that uh, rarely you will die. Okay, because the mortality is less than 1%. Okay, so most of these can be diagnosed with the use of your PCR and antigen, and sometimes so difficult to diagnose using culture and microscopy. Now, you can use also blood diagnostic tests in the form of your the highest yield among these is your antibody test for your aspergillus and your real-time PCR, especially for those invasive type of your aspergillus. Now, as I've mentioned, this aspergillosis can really be a bad microorganism because it can really affect any organs of our body, depending on the stage of the infection. Okay, so for example, if you have an invasive type of your aspergillus, the most common involved organ is your lungs, but it can also disseminate into the sinuses, the brain, the skin, causing also endocarditis and endophthalmitis. Now, the chronic type of your bronchopulm or the chronic type of your aspergillosis, the most common underlying um chronic conditions here are those patients with lung infections in the past, and that's why it can be an opportunistic infection. And in the lungs, it can cause cavitary lesions. Okay, in the sinuses, it can also cause chronic invasive granulomatous lesion, granulomatous disease, or meningitis in the brain, and external otitis or onychomycosis in the skin. It cannot affect the heart and the eye. Okay, and then the most benign among these is your saprophytic, or your in the form of your aspergilloma. Okay, so most of these will have what we call the characteristic fungus ball. So usually it's not so toxic. Usually rarely symptomatic unless you have a very big fungal ball. And then, of course, the allergic bronchopulmonary aspergillosis, which is usually can occur and difficult to differentiate with patients with severe asthma or hypersensitivity pneumonitis. Okay, so treatment here, as I've mentioned, with your aspergillus, especially the invasive one, it's your azole, your voriconazole, your isobuconazole, and then you have your posaconazole. Okay, so you just have to remember that when you will be using your voriconazole, the drug-to-drug interactions, and in some patients wherein they cannot tolerate the azoles, the secondary treatment is with the use of your amphotericin B and your caspofungin or micafungin or your echinocandins. But again, secondary treatment may not be as good as that compared to your primary treatment. No? So these are just some, most of the primary treatment here is usually in the form of your azole. Okay. Now, just an example here of an invasive aspergillus in patients who underwent computed or CT scan of the thorax. Okay, so the first patient is a patient with myelodysplastic disease with moderate neutropenia, and you will see here the characteristic right-sided nodules with minimal ground glass. Okay, ground glass is inflammatory description, no? Inflammation. Okay. Then you also have here a patient with multiple myeloma undergoing intensive chemotherapy using corticosteroid, showing bilateral areas of consolidation, this one. Okay. And you have here an area of non-specific atelectasis and more ground glass surrounding the right-sided lesion. Okay. So for you to really appreciate this, you need to do a chest CT, no? Patients with aspergillus infection. Okay. The last among these is your pneumocystis infections. As I've mentioned, this is one of the most common cause of opportunistic pathogen that will present with pneumonia among patients with HIV. And 80% of cases, if you have an HIV with less than 200, then this is one of the most common cause of pneumonia. And if the CD4 count is less than 100, this is the case that usually should be ruled out. No? So which means the lower the CD4 count, the higher is the Pneumocystis carini infection. Okay, so it can be acute or subacute, meaning acute within 7 days, or subacute more than 1 week, up to 2 to 3 weeks, presenting as difficulty of breathing, non-productive cough, and then progressively have shortness of breath, and then you have severe hypoxemia. So what is the current treatment of choice? So this is the one that I've said a while ago that this is considered a fungal infection, but look at the drug of choice here. It's with the use of your cotrimoxazole, no? So you have to give the high dose of your cotrimoxazole here. You have the double strength, two tablets TID, and then the alternative drugs or the adjunctive agent, which might not be so effective, like your clindamycin plus primaquine, and then the adjunctive agent to prevent more inflammation, you can also give it together with your steroids. No, so just to show you the characteristic appearance of a patient with pneumocystis pneumonia, they usually present with interstitial, no, symmetrical interstitial infiltrates. So you see here in this particular picture, you have this particularly infiltrates here. You have a clean area here in the periphery, but in the interstitial area you have haziness. And then you will see also what we call symmetric alveolar infiltrates. Okay, so very characteristic, evolving from the interstitial area and then spread outside. No, so you can sometimes mistake this as probably pulmonary congestion. But if you have a patient that is immunocompromised like HIV, then you will not be mistaken to diagnose this as a patient with pneumocystis infection. Okay, so I'm now in the last part of the slides. I will just be showing you how bad is global incidence of fungal infection causing annual number of death. No, so it says here the new estimate indicate that over 6.5 billion people, no, annually are affected by an invasive fungal infection. So this is a publication by Lancet Infectious Disease in 2024, so last year. And it shows here the different types of your fungal infection ranging from chronic candida, pneumocystis, you have cryptococcal, you have mucormycosis, you have invasive aspergillosis. No? So that is how varied, no? The varied the this fungal infection. And if you look at how this 120 countries reporting this invasive fungal infection, it seems that you have one that really stands out here is your chronic pulmonary aspergillosis, which commands the one of the highest number of uh, infected globally with a very high death rate at 18.5%. Then you also have Candida, okay, 1.5 million with 995,000 death, which is 63.6% mortality. And then, of course, your pneumocystis pneumonia because of an HIV driven increase in the cases when you also have 505,000 with 214,000 death. No? So one of the highest number of death. So you have the top three fungal infection that globally that are affecting the higher rate of mortality. No? So here, this is just the crude mortality of any of these infection. I'm just highlighting that your Candida, which is common in the Philippines, is one of the top three there in terms of those patients who had higher risk of mortality. Okay, so I think this is my last slide, and of course, my last slide will just be looking at that we were able, no, at the end of this lecture, we are able to discuss any of this, and now it's your turn to really, hopefully, to remember and look at the aspect of fungal infection, one of the most important infections that that also commands a lot of mortality. So with that, I will end this talk. Thank you very much for your kind attention. Okay, so I think